Somewhere in northern India, around the 6th century BCE, a surgeon pressed a bronze needle into the white of a living eye and nudged the clouded lens out of the way. The patient could see again. Roughly. For a while. Whether that counts as restoring your sight is the question this entire procedure spent 2,000 years failing to answer cleanly. Here's what a cataract actually is. Not a film. Not a skin that grows across the surface. That is the mistake almost everyone makes, and it matters because the mistake shaped the surgery. The lens of your eye sits just behind the iris, a small transparent disc that focuses incoming light onto the retina at the back. When protein fibers inside that lens begin to clump and cloud, the structure itself goes opaque. The light still enters the eye, it just hits a wall before it can be arranged into anything useful. What the patient sees is not darkness, it is fog. Thick, uniform, sourceless fog. The world is still there. It has simply been erased by your own tissue. The operation designed to fix this is called couching. The word comes from the French coucher, to lay down, to displace. And that is exactly what the procedure did. It did not remove the clouded lens, it pushed it. A needle or a curved instrument entered the eye at the edge of the iris, found the lens, and levered it downward and backward into the vitreous humor, the gel-filled chamber at the rear of the eye, clearing the visual axis the way you might sweep debris off a window by knocking it to the floor. The lens is still in the eye. It is just no longer in the way. The earliest written description comes from Sushruta, the Indian physician whose Sushruta Samhita is dated somewhere between 600 and 800 BCE, though the manuscript tradition is complex and scholars argue the margins. He described the instrument, the Jabamukhi Salaka, a curved needle, and the general approach with a clinical precision that suggests he was not inventing the technique, but documenting something already practiced. Centuries later, the Roman encyclopedist Aulus Cornelius Celsus gave his own account in De Medicina around 25 CE, describing an almost identical procedure performed across the Mediterranean. Two traditions, separated by a continent, converging on the same needle, the same angle, the same displaced lens. That convergence is either independent discovery or evidence of something traveling along trade routes no one has fully mapped. Now place yourself in the room. You are lying on your back or seated with your head braced against a post or held still by an assistant. The light source is whatever the season allows through whatever opening the room has. The instrument is bronze, or later iron, polished but not sterile, in any sense that would mean anything to the men who would develop the word sterilization 15 centuries from now. The surgeon locates the limbus, the junction between the clear cornea and the white sclera, and pushes the needle through. You feel pressure before you feel pain because the eye has fewer pain receptors than the skin around it, but you feel it. The lens resists. The instrument works against it, and then it gives, dropping back into the dark interior of your own eye, and the fog in your vision shifts. For some patients, the shift was enough. Rough shapes returned. The difference between a doorway and a wall. The outline of a hand held at arm's length. Travelers in the ancient world reported it. Medieval Arabic surgeons like Ammar ibn Ali al-Mawsili, working in the 10th century CE, refined the instrument and described patients who could walk unassisted afterward. The procedure spread from India westward, through Persia, into the Islamic medical tradition, into medieval Europe, where itinerant couchers moved between markets and fairs, operating in daylight for whatever the family would pay. But the immediate result was not the final result, and this is where the procedure's logic starts to fracture. The displaced lens does not dissolve. It sits in the vitreous, a foreign object inside a closed system, and the eye does not ignore it. Inflammation followed a significant number of procedures. The eye swells, clouds, fills with pressure. What looked like restored vision in the first days narrowed again within weeks. Infection was a separate risk, and in the ancient world, an infected eye had one direction to travel. Physicians in the Greco-Roman tradition documented failures. The Talmud references couching and implies familiarity with its hazards. Arab medical texts from the 9th and 10th centuries explicitly cataloged the complications. Secondary glaucoma from the displaced lens pressing on drainage structures, retinal detachment from the physical trauma of the needle's passage, hemorrhage, total blindness. The failure rate cannot be calculated with precision because the historical record is not a clinical trial, but the patterns are consistent enough across cultures and centuries to be read. Sushruta himself cautioned that the operation should only be attempted on patients whose cataracts had fully matured, a piece of practical advice that implies he had watched it go wrong on patients whose lenses had not. Celsus described the same preparation, the same caution, the same implicit acknowledgement that timing was the difference between partial sight and no sight at all. So here is where you stand at the end of the procedure. The needle is out. The lens is displaced. Your vision has either cleared slightly or it has not. You do not know yet which category you are in. The inflammation that will decide your final outcome has not yet started. The infection, if it is coming, will announce itself in 3 to 5 days. You have bought yourself a window of uncertain hope inside a body that is already beginning to respond to what was just done to it. The operation caused enough blindness to be documented across 2,000 years of medical writing, and it never stopped being performed, which means the question is not whether it worked. The question is what working meant to the people who kept choosing it. Start with what the displaced lens left behind, because this is the part the procedure never solved and no one in the ancient world had language for. When the Kaucher's needle knocked the lens into the back of your eye, the visual axis cleared. Light could reach the retina again. That part is real. But the lens does not just block and pass light. It bends it. It focuses it. Without the lens sitting in its correct position behind the iris, the image arriving at the retina is not sharp. It is not fog anymore, which was the condition you started with, but it is not sight the way you remember sight either. What you get is light, shape, the broad geometry of a room, a face, a window. Contrast without detail. The world returned as a rough draft. Medically, this condition has a name, aphakia, from the Greek meaning without lens, and aphakia without any corrective optic to compensate means severely impaired vision for the rest of your life. Not blind, not seeing, somewhere in between, permanently. This is what the procedure actually delivered when it worked. And yet people chose it. Across 6 centuries of documented Roman medicine, across the Islamic golden age of surgical refinement, across medieval Europe where traveling couchers set up in market squares and operated in open daylight for coin, across the Indian subcontinent from Sushruta forward, people lay down and let someone push a needle into their eye. The easy explanation is desperation dressed up as ignorance. Primitive people doing primitive things because they did not know better. That explanation is wrong, and the evidence against it has a name. Georg Bartisch was a German oculist who published Ophthalmodulea in 1583, one of the earliest systematic treatises on eye surgery in the European tradition. He was not a defender of couching. He was one of its most precise critics. He documented its outcomes with an attention that reads less like a moralist condemning quackery and more like a clinician genuinely trying to understand a rate problem. Why did the same procedure produce radically different outcomes in different hands, different seasons, different patients? His records show couchers who achieved lasting functional improvement alongside couchers who left a trail of inflamed, ruined eyes across entire towns. What Bartisch understood, and what his writing makes plain to anyone reading it, is that the practitioners and their patients were not operating in ignorance of the risks. They were operating in full awareness of them and choosing the needle anyway. Because the alternative was not careful, watchful waiting. The alternative was progressive blindness with no floor. Put yourself back in that calculation. No anesthesia that works past distraction and a firm grip. No antisepsis, no microscope, no intraocular lens implant to replace what the surgery removes. And on the other side of the scale, a cataract that does not stop growing. It matures. The fog thickens. The contrast dims. The ability to work, to navigate your own house, to recognize your own children across a room, narrows month by month until it closes entirely. In a world where your physical productivity was the margin between your family eating and not eating, between you being cared for in old age or left to manage alone, blindness was not an inconvenience. It was a sentence. Dependence in pre-modern life had a weight. Modern comfort does not prepare you to feel accurately. So the coucher arrived at the market fair and the family watched, and the calculus was not. Is this safe? The calculus was, is partial vision in a gamble better than certain blindness in a slow certainty? And for a significant number of people across 2,000 years, the answer kept coming back yes. Rough shapes, doorways, the outline of a face. That was enough to change what a life looked like. Not restore it. Change it. What finally made couching obsolete was not the recognition that it was dangerous. Everyone already knew it was dangerous. What changed was the development of extracapsular cataract extraction, the actual physical removal of the clouded lens from the eye, refined through the 17th and 18th centuries and made genuinely viable with the work of surgeons like Jacques Daviel, who performed a successful extraction in 1748 and began publishing results that shifted the standard of practice. Removal meant the source of inflammation was gone. The displaced object sitting in the vitreous, pressing on drainage structures, threatening the retina, was gone. The eye still needed a corrective lens afterward, thick spectacles for centuries, then eventually the implanted intraocular lens that became standard in the 20th century. But the internal threat was eliminated. The failure rate dropped in a direction that made the older procedure impossible to defend professionally. The needle did not disappear immediately. It persisted in regions without access to trained surgeons well into the 19th century and in isolated practice into the 20th. The logic that sustained it for 2 millennia did not evaporate the moment better options existed elsewhere. It persisted as long as the choice remained the same, the needle or the dark. So return to the room. The bronze instrument is out. Your head is still held. Someone is wiping the surface of your eye and asking you what you see. And you report it honestly. Something. Light. Shape. The ghost of the world you remember. Not what you had, not nothing. That narrow ground between them was the entire territory this surgery occupied for 2,000 years. The people who chose it were not ignorant of the odds. They were rational inside a brutally constrained set of options, gambling a working eye they were already losing against the chance of keeping something back from the dark. That is not barbarism. That is just what a reasonable person does when the alternative has already been decided for them.